I'm humbled by the kind introduction, and again, this podium and this stage brings me to very good fond memories of Shaukat Khanam and working in Shaukat. I still work at Shaukat Khanam, and I think the topic that was given to me was also very interesting in a way. Uh, I'll go over why this topic is interesting and why we need to talk about not only in nuclear medicine but in medicine and in endocrine and every field that we need, because it's a common problem. I'll quickly go over the timeline here, what I'm going to discuss in the next 15 minutes, and again I'll try. Let's talk about the thyroid nodule. So thyroid nodule is a bump in the thyroid, we all know. So this, I'm talking to nuclear medicine radiologists, so it's funny that I don't have to, and I'm lucky not to have to describe what a thyroid nodule is. But important factor is a thyroid nodule, and there are nodules that you find out incidentally in examination. I would like to pose this question to you guys, and again think about it, and I'll ask the same question at the end of the talk and see what you guys have to say. Why renewed interest in thyroid nodules? Why are we talking about it now more often than probably not in the past? And that's something that I would like to ask again. Endocrinologists are not super genius people, so we need to keep things simple, and we need to keep things clear for us to make manage. So again, there are 4 things that you need to know as far as thyroid nodule workup is concerned: is TSH, ultrasound, thyroid scan, and probably an FNA. So these are the 4 things that we need to know. What are the causes of it? There are multiples, and I don't want to, in the interest of the time, again, I don't want to go over all the things that we can look into. It starts from the Hashimoto chronic thyroiditis, which can develop thyroid, follicular adenomas, Hurtzel cell adenomas, then number of stuff. These are the benign components of the thyroid nodules. But obviously, whenever you see an abnormal lump or bump in the body, there is a chances of some kind of a cancer as well. And here's a list of the few of the cancers that you can see in the thyroid that you can go, and that starts from papillary to medullary to follicular to anaplastic. And the importance of knowing them, I'll describe in a second as well. So how often should we find an thyroid nodule? And I think this is very important for us. But even more important question is that how many, you guys are lucky you're working in nuclear medicine, so probably you find these nodules very commonly. But in internal medicine, we don't, if you ask a good physician, how many nodules did you find out in a day's time, probably he will say 1 every week, not more than that. But if you look at the literature, the incidence varies from 1% to 2% to up to 76%. So there's a huge number of people with thyroid nodule. I can bet that if you scan everyone in this room, about 30 people would have a positive nodule that you need to, that will be picked up by the ultrasound. So that's something that you need to find out. In autopsies, you can find nodules in up to 50%, 37 to 57% of the people. So it's out there. It is there, and what you need to find out is how to do with it and how to proceed with the treatment component of it, and that's where the tricky part is. The problem is, if you remember the 4 things that I've discussed in the beginning of the slide, people use it up and beyond their capacity, these instruments. These are the tools that you can use, but people misuse it in multiple ways, and they order everything. And then the cost of doing investigation becomes so high that once you find a nodule, you shy away from investigating because you know the cost of doing the scans and everything is so high. So that's something. So does a thyroid nodule means a cancer? Actually, if you look at the data, 95% of all the nodules are benign nodules. So the list of the benign nodules that I told you, they are benign. And about 5% of those cancers or nodules are cancer. And vast majority of them are treatable, curable, papillary thyroid cancer or a follicular thyroid cancer. So that's something that we should be aware of, that the cancer risk is much smaller, and whatever cancer you have, it's much more treatable like a papillary or a follicular cancer. So risk factors for thyroid, if a nodule, what are the risk factors that you probably end up with a cancer? If you have a nodule at a younger age, probably you're more likely to have cancer. If you are diagnosed with a nodule less than 30 or above 60, probably that's the time that you will have more chances of it. If you're a man having a nodule, that's high likelihood of developing cancer. And obviously, if you have a radiation history. The importance is, especially in the children, it's very important to pick up these, because people at children age, you get a pubertal goiter, which is different than a nodule. And if you have a nodule, probably you'll have a higher chances of developing cancer. But if you have a pubertal non-nodular goiter, this is something that you really. So if you're looking for it and looking for it in the wrong place, probably that's not the right approach. What is the mortality of it? That boils down to what is important and what is not important. The chances of having a death from a cancer. So if I see someone with a nodule with a suspicion of cancer, I usually tell them, if you have a choice by a God, that which cancer would you have, probably this is the cancer that you would want to have, because probably you can have this taken out and you're cured from it. About 25-year mortality if someone is diagnosed with thyroid cancer is very high, is very low. It's less than 2%. So probably most of the people who end up having a cancer get cured and they are all fine in years to come. And this is the experience from Shaukat Khanam as well. These people are perfectly fine. They do. If you look at the autopsy, you will find about 6 to 13% of the people who are dead for some other reasons. On autopsy, they found the papillary or micronodular or microcarcinoma in their thyroid gland. So just like prostate, where the incidence of prostate cancer goes up significantly higher if they get older, this thyroid cancer also, you can say, a microcancers in these individuals. And I think that's very important for us to know. So the problem is, if we talk about the benign nature of the nodules, if we talk about the curable nature of the thyroid nodules, then why do we need to even do a thyroid scan and thyroid ultrasound, and why do we need to look at the micro? If you have a small nodule, why do we need to worry about it at all? And I think that's important point that we should be able to communicate to our colleagues, because that is something, because about 15% of these differentiated cancers may act aggressively. Some of them may have metastasized to other places. With that, the mortality goes up. And there is obviously incidence of anaplastic cancers and the medullary cancer, which have a higher mortality as well. So not all microcancers can be ruled out. So hence the investigation is important. Hence we need to find out what's there. Hence we need to treat them accordingly, what needs to be. What are the tools that we need to evaluate? And again, what are the diagnostic use of the FNAs? Fine needle aspiration is probably the most significant. We used to use thyroid scans a lot in the past, but honestly in current time and age, and I'll go briefly where the scan can be used, when I see a referral for a thyroid nodule, it's always done with a thyroid scan and an ultrasound and the thyroid function test, and sometime even a CT scan or something of that sort before I see them for further evaluation, which is probably not the right approach. And I'll try to give the right approach as we go along. And obviously high resolution ultrasounds do a wonderful, thyroid score does a wonderful job. What do you look for it in a thyroid nodule? You need to look at the nodule size, where is located, what is the size of it, how are the margins looking like, if there are some regional lymph nodes, if there's calcification, if there is vascularity. And I'll try to give you the thyroid score by the American College of Radiology, in which you look at different components of a thyroid nodule and you call them different thyroid level. And obviously all of you guys know, the problem is that if I order an ultrasound of thyroid, in 99.999999% of the time, I will get a report. When I've ordered a thyroid ultrasound, I will get a report that this person has a 2-centimeter nodule. That's it. We don't even talk about the thyroid score, and there are only hand-picked places that you can write, please give me the thyroid score, and then you get the thyroid score. And it's important to know the thyroid, because your diagnostic approaches change based on those thyroid scores. So that's something that we need to know. And again, the concept of thyroid score is amazingly missed by most of the radiologists when we get a report, which is such a sad thing when we look at it. I don't want to spend too much time obviously in the thyroid scoring and whatnot, but again, FNA is the next possible score. And why thyroid score is important? Based on the point, you can label them from 1 to 5, And if you could look at the slide, the chances of having a cancer goes up higher if your thyroid score is higher. And hence, if your nodule size is of 1 centimeter or higher, if your thyroid score is 5, or if it's 2 centimeter or 2.5 if the thyroid score is 3, you need to put a needle in and find out if there's something suspicious. Otherwise, you can monitor them on ultrasound if they have a lower thyroid score. So something that you need to know. And again, if you're ordering a test which is thousands of rupees and not getting the reports, I think that's very sad affairs, and I think that's the problem that we say. As a general rule, honestly, even if you don't get a thyroid score, if you see an irregular margin, and if you see microcalcification, if they are taller than the wider, if they are macrocalcification, if they are calcification on the rim, or any combination of it, that should raise your eyebrows. But sadly enough, honestly, we don't even get those in an ultrasound in most of the cases, and they only tell you the size of the nodule and nothing more than that. I think that something has to change. That's something, and thank you for bringing me to nuclear medicine. I would love to give a talk on radiology as well in the conferences as well, because this is something I as an endocrinologist miss, because I have to do the ultrasound all over again. I told you about, we discussed about the children with high risk of cancer. We need to be very careful, because if they have a nodule cancer, thyroid, probably we need to look in. And these are all the signs and symptoms of what you're looking at. If you have a solitary nodule, if you have a big calcification nodule, these are the markers when you need to put a needle, because in a younger age, the cancer risk is higher, as well as you need to be worrying about the long-term complication of it. How do you work up in an incidentaloma? Again, the challenges I've clearly mentioned. We need to order simple things first. First a TSH to look the functional status, and then investigation, and I'll briefly. There are few interesting cases and few interesting things that we need to know about as far as thyroid nodule. And this is again one of the biggest misconceptions that I come across. In a multinodular goiter, you cannot have a cancer. If you have a multinodular goiter, and if you have a suspicious nodule, you have an almost equal chance of having a cancer in that one single nodule when you look at someone who only has one nodule and has the same size. So you need to make sure that even in a multinodular goiter, you need to. So what the ultrasound report that I'll get is a multinodular goiter with nodules varying anywhere from 0.5 centimeter to 2.5 centimeter, and that's the report I would get. Honestly, it's a useless report for me, because I know if I'm seeing a big goiter, they will have nodule, and it will be multinodular, and you need to give me the size of it. If you have one nodule which is big in multinodular, and if two, there's another one on the other side, the chances of having a cancer again is very high, even if you compare it with a single nodule in a thyroid. So something that we tend to forget. Low TSH values. If you have a TSH which is low, again, please make sure that you rule out any causes of hyperthyroid in these individuals, because hyperfunctioning nodules are not usually malignant. So you need to go through, this is a time that you would want to do a scan to find out if there's anything or not, and that's where all of your specialty comes in. And if you are pregnant and have nodule, thyroid cancer grows slowly. So this is not the news that you want to break it to the patient and say, you know what, you need the surgery now. If they are euthyroid, if they have nodule, if you can follow their nodules, you can follow them over the, you can do an FNA in the first 2 trimesters, and you can even have the surgery done in the 3rd trimester, but there's hardly a case when you would need to do an emergency surgery in these women. You can wait for them to deliver and then stabilize and then get the surgery done. What if you're pregnant as well as you have an intermediate FNA which shows some kind of an intermediate reporting? Probably these are the people you can also wait and follow it through an ultrasound. Wait till 24 to 26, follow the size of the nodule. If they are not growing by an ultrasound, probably you can wait after the surgery. If they're growing too fast or their symptoms, probably these are the individuals you would. In the last 2 minutes, I'll try to give you a summary of what we know about thyroid. So I personally think we need to, just like if you look at the calcium levels, and if they are high, what's the first thing you do? You look at if they are PTH dependent or non-PTH dependent. For me, nodule, we need to look at the thyroid. If the TSH is suppressed, you go the route of hyperthyroidism. If the TSH is normal, that's the time that you go for an FNA based on the thyroid score. And these are the 4 possible things that you can. If it becomes if it's a non-diagnostic one, probably you need to repeat it. If it's a benign one, you need to follow and observe it. If it's high chances of malignancy, you send them for surgery. And if it's intermediate, again, that's the time that you would want to again utilize. This is the only time that I would want to utilize a thyroid scan, because if the thyroid scan, if you have a lesion which is follicular and it lights up on the scan, probably it's not a malignant one and you want to go in the line of observation. But if it's a cold nodule, probably you need to send them to surgery, and if it's a hot nodule, you need to observe and follow these people. And I've seen people even use radioactive iodine. So that's a summary of how I would approach a thyroid nodule, starting from the TSH to the chances of malignancy to the survival, as well as using. I cannot stress more that we need to make sure that we use the right tools. Unfortunately, if we overspend on the investigation, people get frustrated as well. So this is a picture from Texela, and I think I went there about a few years ago, and I thought there were a lot of hypothyroid and thyroid goiters in Texela time as well. And if you look at the pictures, this is the picture you'll see in most of the cases. So my last question the question that I asked, and I want to finish off with, why a renewed interest in thyroid? Or why did Humayun and Saima decided to call me up for talk about thyroid nodule at this time and age? Any idea? Can you know why is there all of a sudden more interest in thyroid nodule? GLP-1s. So somehow there is a theoretical risk of medullary cancer if you're using Ozempic or semaglutide or tirzepatide, and the whole world is on it right now. Although the risk is only theoretical, there's not enough data to say that this is very common, but everyone who gets the thyroid, who gets started on GLP-1, have the ultrasound of the thyroid done in a civilized world. And guess what happens? They have an ultrasound. As we talked about, 70% have nodules, 50% have nodules. They pick up a nodule, and hence the investigation for nodules starts all over again. So I see a lot of people going through under workup of thyroid nodules in this world, not because of the higher incidence now, but because of the use of GLPs in the world right now. With that, I thank you all for your attention, and I'll leave the podium. Thank you.